Hello, everyone. This is Jessica bringing you the Block 1 wrap up. Just want to congratulate everyone on a successful completion of Block 1 in the lower extremity management course. This wrap up will kind of go through some of the highlights of the week and go into some housekeeping items for the next block coming ahead. This week, we touched upon a few topics, and first we're going to talk about the medical screening. There was a lot of really great case examples of how you guys are able to demonstrate your clinical reasoning and how to manage patients through different types of access, whether they're coming in direct access, whether they're referred. I remember one case, I forget who it was, but I think a patient just came in off the street wondering what was wrong with their leg and had to kind of problem solve and get them to the next point of care, which is an extremely important skill that we need to own as physical therapists as we continue to kind of push ourselves into that primary care role. The medical screening is also continuous over the entire course of the care because anything can change or come up within the course of your care with the patient that you'll have to continue to monitor. A lot of the case examples talked mostly about kind of red flag screening and how to refer on to that person, but we also have to be aware for a lot of yellow flag screening too. And there's some good discussion on what types of forms or we would use to kind of establish whether that patient has any yellow flags contributing to their current symptom behavior and potentially impacting the prognosis. There was also a lot of information this week through kind of the PowerPoint presentations from Laura and some of your readings about screening exams or screening tests for identifying potential conditions that would indicate the patient needs to be referred on for further evaluation or diagnostics tests and procedures. So I just like take a moment here to kind of remind everybody that we want a very highly sensitive test when we're screening to designate a patient that may be positive for a certain condition. We want a highly sensitive test because that means there are very, very few false negatives or cases actually missed. So a good example that was talked a lot about on the boards was the Wells criteria. With a low cutoff score of 1, the Wells score is able to rule down the presence of a DVT with a sensitivity of 100% and also negative predictive value of 100%, which is about as good as a score a screening test can get. The next area to discuss is the Suki article, the Regional Interdependence Model for Musculoskeletal Dysfunction. I pulled in this little picture here from the article because I thought it well depicted the discussion we were having on the boards, where both the local and remote responses can often impact a musculoskeletal response. So we need to be looking at the area of complaint and above and below the area of complaint and or even the spinal region referring to that. So for the lower extremity management course, that could be anywhere from, T8 on down to the toes. So we need to be aware of those referral patterns. Other areas of referral we need to be aware of the somatovisceral referral. Could there be kidney referral referring to the low back area, the ureters referring to the groin? Could there be an abdominal aortic issue or aneurysm causing a vascular claudication in the lower extremity? So we got to keep thinking that there still could be some red flags or non-musculoskeletal issues going on when we're developing our hypothesis. And we continue this process throughout, especially when our patients are not responding to traditional physical therapy. Then there's also the biopsychosocial approach, and there was a lot of good discussion on the boards about what kind of outcome measures or you would use to identify people that may have poor prognosis due to influences such like as fear avoidance issues, high pain catastrophizing issues, And expectation, we all know that now that expectation can have a big impact on whether the patient does well or does not do too well. Then we also have the neurophysiological impact on our symptoms. And there was a lot of good discussion on the boards about applying, a high velocity thrust to one area that can have symptom modulation into a different area. So there's a whole lot to think about with just one small little muscular response to get the best outcome for the patient. Then we had our case study. There was a lot of questions on the board like, well, I need to know this, I need to know that, which is great. I think you guys are thinking ahead. But the point of this area was to just see the body chart and then start to gather some thoughts about what areas could be causing the problem directly under the area, and again, what can kind of refer to that area. And then we can use that list of structures that could be contributing to the symptom behavior to start to develop our hypotheses. So there are a lot of good examples out there, and this is going to be a really big, broad list of structures and structures that refer to the area, then that we funnel down as we get more information as the case study progresses. There were a couple discussions that I want to kind of point out that I thought kind of went to some interesting places. Corey, if you go to his initial post in Group Alpha and kind of read the thread, there's some good discussion on whether or not we should ambulate if a patient has a DVT. And I think it's just kind of good information for you to go there, and there's some good references posted. I think I don't want to assume too much, but I think there's still a big trend to if they have a DVT, let's not move them. Right? The clinical practice guidelines now are saying, no, we do need to get these people up and move them. It's actually better for them in the long run. And then Armin in Group Bravo, if you kind of go through and read his whole discussion thread, kind of took a little nice turn in the discussion into some sort of pain science educations, how and when you're going to do that, and they provided some little additional resources there. So kind of looking ahead, make sure you're familiar with the calendar. We're going to stay in the same groups for this block. Make sure if you have any outside references that they're in the shared Dropbox folder, which there's already a whole lot of content in there for block 1. So next up we have the management of selected hip disorders. So go ahead, you can start reviewing that information and get ready for your next post. If you are MTC or resident in the virtual round, you should be getting some emails pretty soon, planning for your live case presentations and video recorded presentations. And that's all for this week's wrap up. If you have any questions or concerns, please feel free to contact me via email or phone number. And I'll look forward to seeing you guys on the boards.